Okay, hi everybody. Today we are going to talk about ears, nose, mouth, throat, and sinuses. Okay, let's get started. This is your case study. Okay, the nursing staff in the care home has noticed that Mrs. Smith's hearing has been diminished. Oops, sorry, has been diminished and should be assessed. What questions should you focus on for hearing loss? So some of the questions that you want to focus on include, you can ask Mrs. Smith when she started noticing her hearing loss. Was it something that came on all of a sudden or something that was gradual? You can ask her, are there certain words or sounds that she hears that she has experiencing more difficulty hearing, such as consonants versus vowels? You can ask her about if she has that feeling that it sounds like the voices that she's hearing or the words that she's hearing sound like they're like either in a barrel or underwater. You can ask her how her hearing loss has affected her functional day-to-day activities. You can ask her, has she seen a doctor? Did she receive any treatment? Did she get, like hearing aids or any other kind of treatment like that? So those are, some of the different questions that, you can ask. And which cranial nerves would you test and how would you test them for her hearing? So you would want to test cranial nerve number 8, acoustic or vestibulocochlear, um, called the same name. Um, so you want to test her. You can do two different tests. You can test her for um, her hearing using the whisper test. What you do for the whisper test is you're going to press on the tragus. That's the flap of skin. It's sort of shaped like a triangle, just in front of the ear canal, press on it, and then you're going to cover your mouth so that she can't see what your lips are doing, and you're going to whisper in the ear that is not plugged, the other ear. You're going to whisper 3 two-syllable words, right? And when I say whisper, I mean really whisper. So you can say something like baseball, football, Tuesday, and then the patient repeats it. And whatever you do with one ear, you do with the other ear, right? 3 different words in the other ear. They need to be 2 syllables. The reason is because sometimes it can be hard to hear just a one monosyllabic word. So you want to do 2 syllables. The other test you want to do is called the Romberg test, and that's for balance because we know that the ears govern not just hearing but also balance. So what you want to do there is you're going to ask your patient to stand with their feet about shoulder width apart, arms down by their sides, and they close their eyes and they hold that position with their eyes closed, just standing for about 20 to 30 seconds. And you would just kind of hold your arms on either side of them just to make sure that they don't fall. They should not fall. They should be able to maintain their balance without falling. And also just use some judgment here. So if your patient is much bigger than you and is at risk of falling, you do not want to be doing this test. Even if you don't know if they are at risk of falling, you still don't want to do the test on your own because if a patient is very big and does wind up falling, you don't want them to get injured. So as I say, you just use some judgment when you're doing this test. Okay? So I'm just looking for my cursor. There we go. 1 month later, Mrs. Smith states that she has maxilla pain along the cheeks and nasal stuffiness and a sore throat. What abnormal findings would indicate chronic allergic rhinitis, and what other tests can be done? So, if she has a stuffy nose, if her mucus looks pale or gray, or looks, a little bit, um, puffy, sort of swollen, that would be an indication of chronic allergic rhinitis, that there's a lot of mucus in her nose. So you want to do this, but you want to do to check this out is you take the otoscope, right? Not the ophthalmoscope. That's the one that looks in the eyes. This is the otoscope, which you use to look in the ears, but in this case, you're going to use it to look in her nose. You just want to make sure you put a probe over the cover. The otoscope is the one that has like a little probe that kind of sticks out. So you always cover that end with a probe, and you can just lift the nose ever so slightly like this, and you're going to look in the nostrils just to take a look and see the color of the mucosa. Um, what you should be seeing when you look at the turbinates inside the nose, that's where the air goes in and gets filtered and warmed for the body. When you look at that, it should look deep, deep red, like a nice, healthy red pink color. It should not look very pale, light pink or gray. That would indicate something like this, allergies or allergic rhinitis, um, a really, really bad cold going on for a long time. So that's what you want to do when you're going to take a look inside her nose, just to make sure that, everything, is clear. Or not, or that, um, that she does have, something going on, hay fever or something like that. Just keep in mind that if the nose if the person has a stuffy nose, ask them to blow their nose before you do the test. If you know that if there's, something like, you know, um, yellowish greenish mucus that's coming out that indicates infection, you always look at the nostril that has the infection last. Okay, so in other words, you would never examine the one with the infection and then, take the probe and carry it to the other nostril, right? Either, if you don't know, either you're looking in and you notice that the mucus looks, greenish yellow, you would take that probe off and put a new probe on to look at the other nostril. Okay, just to maintain, hygiene. Um, just to go back also, since we're talking about the otoscope, you can also take a look in Mrs. Smith's ear when you're examining her ear, if she's complaining of difficulty hearing. And you can also just take a look, same thing, always put a probe on the cover when you're looking in your patient's ear. When you're looking in the ear, think of the same thing as when you'd put, when you're looking at, not looking at, but when you're putting in the thermometer when you're taking a temperature. So you always want to make sure that you're going to pull the pin up and back when you are taking a temperature, and also when you're putting in the otoscope. So you put in the otoscope, it has a light, is sort of part of it. So when you're going to take a look down the auditory canal, you're going to keep going down the auditory canal, keep going till you see the end, which is the actual eardrum, the tympanic membrane. It's also known as the eardrum. You want to just take a look at it. It should look sort of like a pearly gray color. And it almost looks like the inside is sort of pulled kind of inwards, like not towards. It shouldn't be bulging and red, towards you. It should almost be sort of pulled inwards, facing away from you. And yeah, you just want to take a look. You should be able to see sort of a cone of light, the reflection of the light that's in the otoscope. You should see it in the eardrum. Sometimes you can see those little bones behind the incus, the stapes. You might just see, as I say, some of those, the three little bones. Sometimes you could see that in the eardrum, and it should look round. It should look, as I say, either flat or kind of pulled in a little bit. You should not see any holes or any scars in the eardrum, but if you do, that could be an indication of the holes could be sometimes if people are having little children who have repeated ear infections, sometimes they put an actual hole in the eardrum to drain fluid so that the fluid doesn't push against the eardrum, cause a lot of pain. And if that happens repeatedly, sometimes all that pushing against the eardrum can cause it to burst, and all of the infection, the mucus, and all of the pus and everything going on behind the ear, which is causing it to bulge and look red, can start dripping out. So if that happens repeatedly, every time an eardrum bursts, it can scar. So what you're looking at when you're looking at the eardrum, you want to take a look that there are no scars. But if you do see scars, that is an indication that the patient has had, a few eardrum has burst a few times. And yeah, if that's happening a few times when the child is younger, to prevent that from happening, because you don't want that to become a problem later with hearing loss. Sometimes what they'll do is they'll put a little hole in the eardrum to help drain the fluid, because the main pain that a child feels is really that pressure behind the eardrum. That's what causes it to bulge and look very red and like press against the mucus behind us, pressing against the eardrum. And that is what causes a child pain. So if that, even though it looks gross and gunky, but if that pressure can be relieved by putting in a little hole, sometimes that's what's done. So there's little holes sometimes that are put into the eardrum. And if the child, when they have a bath or a shower, or when they go swimming, there are these special earplugs that they put in so that there's no ear that goes into the down the auditory canal and into, behind the tympanic membrane. So you can take a look inside their ears. You can take a look inside their nose when you are testing. looking for any problems with the tympanic membrane or any problems here with something going on in the nasal cavity. You inspect inside Mrs. Smith's mouth, and notice that the tonsils are touching the uvula. What is this grade? So we actually do grade the tonsils when we look at the tonsils. 0 means no tonsils. So that means that the tonsils have been removed. Sometimes you can see the scars when you take a look inside your patient's mouth, their throat, I should say. Or you might see tonsils that are like just kind of very much sort of in that in the corners almost, and that's a 1+. A 2+ is when they're actually visible. A 3+ is when they are touching the uvula. That's the thing that hangs down in the middle. And a 4+ is when they're touching each other. So in this case, you notice that the tonsils are touching the uvula. That would be a 3+ grade. Okay, Mrs. Smith's teeth appear yellow. The incisors have vertical cracks and gum margins have receded. Is this a normal finding? So just keep in mind that your patient, Mrs. Smith, is in a care home, right, as we said from the beginning. So she's an elderly patient. And so in this case, the teeth get yellow with age, right? Sometimes it's hard to know because people do a lot of teeth whitening. But if you don't do any teeth whitening and you just don't do anything to your teeth will become more yellow with age. It's just an aging process. The teeth can also crack with age, as it's what's happening here. Incisors have vertical cracks. It can be incisors or it can be any tooth can start to crack with age, wear and tear, exposure to the elements and the environment. And the gum margins have receded. Yeah, so that also can happen with your patient or with people who get older, I should say. The gums recede more with age, right? So these are all normal findings because of Mrs. Smith's age, that she is in a care home, that she's older. It wouldn't be as normal if she was younger. So it's context dependent, right? It's only normal because of her age. 2 weeks later, Mrs. Smith is having difficulty swallowing her food. What tests would you perform to assess Mrs. Smith's swallowing? What is difficulty swallowing called? And what other tests would you want to perform? Okay, so difficulty swallowing, let's just sort of take them one at a time. That's dysphagia. So she's having some dysphagia. That's different from aphasia. Aphasia is when you have difficulty speaking, and either you can't speak at all or just having some difficulty speaking and you speak a little bit. So that's the difference between dysphagia and aphasia. So assessing your patient's swallowing. So you want to, and what tests and what cranial nerves are you testing? So you want to test a few different things. You're going to test cranial nerves 9, 10, and 12. So cranial nerve 9, glossopharyngeal, cranial nerve 10, vagus, and 12, hypoglossal. So you want to assess if she's having difficulty swallowing. You want to know, does she have a gag reflex? So one thing you want to do to test cranial nerves 9 and 10, glossopharyngeal and vagus, do the gag test, gag reflex test. Just put in your tongue depressor, just go to the back, all the way to the back of the pharynx, touch the back wall of the pharynx, just in the back there. Just kind of do it quickly, just go in and out, and that will stimulate the gag reflex. You can also test those cranial nerves by and her ability to be able to swallow, or the coordination of those or efficacy of those cranial nerves. Ask your patient just to speak. If she has a very hoarse, unusual sounding hoarse voice, that can also indicate a problem with cranial nerves 9 and 10. And the other thing that you can do is you can ask your patient to say ah. And when they say ah, take your pen light or your light when they're saying ah, so you can see at the back of their throat, the pharynx. And you should see when they say ah, the uvula rises and the tonsillar pillar opens. So you should see those two things happen. That's why when you say ah, that's what your doctor is looking at. And when you go to the doctor and they say ah, that's what they're looking at to see the functioning of those cranial nerves. You can also assess cranial nerve 12, which is hypoglossal, and you can ask your patient to stick out their tongue. It should be midline with no tremors. You can ask them to put their tongue in their cheek, and then you press against it for movement against resistance, and the other cheek, because whatever you do to one side, you do to the other side. And you can also ask your patient to say light, tight, dynamite. And the reason you want them to say that is because this is all about the movement of the tongue. How can the tongue move? Can the tongue move? Can the tongue move against resistance? Can the tongue hold itself in place without tremors, without moving around? So those are the tests that you want to perform. And that's it. So that's what you're going to be doing in the lab. You're going to be using the otoscope to look in your patient's ears. You're looking in your patient's nose. Remember always to change the probe cover and testing those cranial nerves. Okay, I will see you guys later.